very welcome to today's session. And this is part of the overall HCI webinar series. My name is Oonagh Gilvarry, and I am the CRO, the Chief Research Officer in HCI. And we are today going to be spending a little bit of time looking at some of the more recent findings that have arisen from HIQA inspection reports. And from that, we're going to try and identify some of the key areas of focus and concern, I suppose, in relation to HIQA, and then trying to apply that as a learning for your own services as you work towards compliance and ensuring the provision of safe, quality care for your residents. So let's get into it. First of all, just briefly in relation to HCI and what we do. So we help providers of health and social care to make intelligence-driven decisions to attain, manage, improve their quality, safety and regulatory compliance. And we do that through streamlining, supporting and transforming services as their own internal process with a focus on ensuring safe quality care. What I wanted to do this morning before we get into the kind of forensic analysis of the individual reports that we looked at that were released up to April of this year, I want to just have a little look at the overview report that HIQA released in December of last year. And I want to do this because I suppose it's showing some of the key indicators that are then reflected again when we look at the findings from the reports as they come through, which makes sense because that's the information that's held in their heads as they move from one year into the next. But just wanted to look at some of those and see how they're reflected within the more recent reports. Just generally an overview, we can see that year on year from 2020 to 21 to 22, there's been an increase in the number of announced and unannounced inspections, but I suppose primarily in relation to those unannounced inspections. And they've detailed that since March 2020, the number of those unannounced inspections increased, with the announced decreasing significantly. And that trend continued into 2022, where really the only announced inspections are coming through where there are applications to register new beds. If they look at the overall levels of regulatory compliance that they've presented to us from 21 to 22, it's pretty much similar. I mean, we're on the balance of the numbers that are provided to us. They really are very comparable. And I suppose the question is, how are we not improving our levels of compliance and reducing our levels of non-compliance? Well, there is continual development in relation to the requirements. So I suppose the benchmark is being moved, new guidance being released all the time, so that there is that drive towards continuous improvement. And in that regard, I suppose the levels of non-compliance are being recognised throughout. From 2022, the four top spots, and unsurprisingly, these are the ones that are fulfilling the top spots in our more recent reviews. So we've got governance, fire precautions, premises and infection control, with the highest levels of non-compliance across the inspections completed in 22. I just wanted to pull out some of the key features as they talk about them within the report. They do, under governance and management, talk about the consolidation of nursing homes, and really that being the big feature of the nursing home sector throughout that period. And they identify that there is a major risk with that model. That risk being that if there was a failure of one of these larger corporations, it would significantly impact on the number of nursing homes and, more importantly, on the number of residents. And if one of those consolidation groups was to experience financial difficulties or were no longer able to operate, then the legislation requires the HSE to make alternative arrangements, and that would be a significant challenge as it currently stands. I just wanted to pull out some of the common issues, because again, we're going to see these common issues repeated as we get into the more recent inspection reports. But interestingly, fire precautions, as we said, as we've seen already, it was a hot topic or a key area of focus in 22. Significantly, it is a primary area of focus in the more recent ones. And interestingly, it was the only regulation that carried a high red risk rating of non-compliance in the inspection reports that we reviewed more recently, and we'll look at that in a little while. But common issues in 2022, we had inadequate containment of fire, inadequate arrangements to safely evacuate residents, poor risk identification, management of fire safety risks, inadequate means of escape, and poor precautions against the risk of fire, such as inadequate storage practice and attics used for storage, etc. So they were the primary areas of concern. Other ones relating to it, this is in relation to premises now under Regulation 17, residents not having adequate floor space, insufficient communal space, general damage to decor, inadequate storage, insufficient numbers of toilets or showers, outstanding maintenance issues, and limited access to safe outdoor space. So they were the trends that they identified in that regard. Infection control, also in that bundle. Interestingly, limited antimicrobial stewardship was listed as number one on those common issues, and a lack of adherence to those standard and transmission-based precautions. Ineffective audits comes up a lot in relation to inspection, to IPC. In many facilities, I suppose, still implementing more of a tick box exercise than a forensic analysis of the IPC processes that are being implemented. So that's certainly being called out. Limited or no visiting risk assessments, I suppose, as they linked into COVID. Ineffective oversight or supervision of cleaning practices. And that is coming through again, where registered providers being called out for inadequate oversight or supervision of IPC. So again, pushing that responsibility up to the higher levels within senior management, and issues with training also in IPC. Linked to this, and I suppose worth certainly our consideration as we're looking at levels of compliance and issues that are coming up within HIQA inspection reports. I'm sure all of you are aware that in January of this year, 3 new guidance documents were released in relation to designated centres for older people. So that guidance for the assessment of designated centres, that judgment support framework that they will be implementing, and also a judgment support framework for specifically IPC. And the justification for the update is that the guidance on the assessment of centre reflects the commitment of HIQA to have a more human rights-based approach to regulation, together with evidence-based changes since it was first published, and it gives greater detail to inspectors on the making of judgments about compliance. So when we have queries in relation to what is compliant, what is not compliant, you know, how is it subjective or not, these documents are certainly central as a knowledge base for us to be able to build up our understanding for the approach that HIQA takes to their on-site inspections. Okay, so getting into the more forensic analysis as it arose. So in this case, HCI looked at 36 randomly selected HIQA inspection reports. These were released up to the 10th of April of this year. And we looked at some of the key areas of interest and the types of findings that were being identified under these regulations. So if we look under the first dimension, under capacity and capability, not surprisingly, we're going to spend a little bit of time on governance and management, again, it being one of the key areas of concern. So all of the findings that we've identified here are orange: compliance, moderate level of risk. So as we kick off, the registered provider did not operate the centre in line with its conditions of registration. So there was a number of communal areas which were dedicated for residents' use, had been repurposed without agreement with the chief inspector. So that was identified as an area of concern. The centre's deputising arrangements for the person charged were not being adhered to within the inspection date. Deputising arrangements certainly came to the fore, as you all know, in relation to when we were at the depths of COVID. Where there were individuals that were really in a position to step up and take on roles and responsibilities within senior management should that individual have to step out of the services. And that remains the case, certainly right up to today, that they're looking for real implementation of deputising arrangements, and that those individuals have the skills and competencies and capabilities to fulfil those roles if required. They found that recent changes in a provider's senior management team did not ensure the lines of authority and accountability were clear. And as a result, a complaint about safeguarding was not followed up as required by the provider. So really making sure that our governance structure and framework is sufficiently robust and comprehensive, and that those terms of reference and agendas are clearly detailed, that there's minutes that are detailed to drive continuous improvement throughout the service. The procedures that were in place to ensure residents' voices were heard and used to inform service delivery were not being implemented effectively. For example, there were only 2 records of residents' meetings held in 23, and informal complaints or comments from residents were not being recorded or used to identify these improvements. So really, that lack of engagement with the residents within the services. And we know with the focus, as I said, just with those updates and judgment support framework, focus on human rights and engagement involvement in the service is certainly really central and should be pushed by the governance model that's in place. The annual review of quality and safety, again, did not adequately assess whether the care was being delivered in accordance to the relevant standard. Again, nor was there evidence that it was prepared in consultation with residents and their families. So they're really looking for that level of engagement with residents and their families to try and support the development and improvement of the service. The registered provider had not put in place effective management systems to ensure the care was safe and appropriate. Examples of this: audits were not scored, tracked, or trended to monitor progress or drive improvements. And again, that focus on audits has been one of the key tools to drive continuous improvement in the service, and ensuring that those audits are sufficiently robust and completed by people that have the skills and capabilities to do that. The Centre's governance meeting minutes were not robust to drive quality improvement and did not show evidence of actions required from audits being discussed. So again, looking for that cyclical transfer of information within the service. And there was inconsistent and poorly defined systems to escalate risks to senior management. And again, it's about that open level of communication that is required throughout. If we just look briefly at records then and some of the findings in relation to that, they found that policies and procedures, while they were there as required by Schedule 5, they were poorly organised, very difficult to review, and not easily accessible by the staff. And we see this time and time again in numbers of services where they have quite good policies and procedures, but they're not being implemented within the services. They're not on the line, they're not incorporated into the day-to-day activities, as they're not really accessible, or they don't have a meaningful presence in the day-to-day activities being implemented. Inspectors found some records were not safely secured. A number of archived resident records were located in a maintenance shed prior to disposal, and a door-to room where records were stored were being unlocked. Was unlocked at that time. In a sample of staff files, a number of files did not have satisfactory history, gaps filled in relation to employment, and that some did not have those written references from a recent employer. So again, something to keep in mind in relation to our records. One staff member had commenced employment 2 weeks prior to the vetting be received. And again, we see this every single time that we do one of these reviews with the demands, I suppose, for staff, and that is the risk of staff members actively providing care and support without their Garda vetting being in place. Rosters came under a certain amount of focus also. The roster was not an accurate reflection of all persons working in the centre, or was it a record? It wasn't evident whether that roster was actually working within the service. The roles were not accurately described. For an example, we had an assistant director of nursing on the roster as a clinical nurse manager. So they're looking for real accurate reflections within that roster so that they can get a real feel for the staffing arrangements that are in place on a day-to-day basis. Complaints always comes up for a significant amount of interrogation, particularly, I suppose, with the update in the relevant regulation just last year. In this case, the registered provider failed to meet those requirements, details of complaints weren't fully recorded. Some complaints were closed out with any evidence of investigation or actions being really taken. The satisfaction level of the complaint was not always recorded. That is often missed within the complaints process to ensure that we were providing feedback to the complainant and documenting their level of satisfaction in that regard. And they found that the opportunities for learning and quality improvement were not identified and communicated to staff. In one case, a provider had recorded only one complaint since the last inspection, and that complaint hadn't been followed up in accordance to their procedure. You know, the service that you're all providing is a live service. It's not realistic to think that there would only be one complaint or one level of or one communication of feedback since a previous inspection. And I think certainly HIQA would be much more comfortable when they see all of the information being pulled and documented, whatever types of information that it is, so that at least it's been documented, trended and reviewed, rather than just a single complaint or no complaints being recorded. I mean, that is not realistic in the types of services that are being provided. In another case, there was no nominated complaints officer, and staff and residents didn't know who that person would be anyway. And there was no mention of this review officer and the review process. There was no detail about the provision of regulatory timeframes for conducting this secondary review or the written responses as required from that review. There was no provision for the access to advocacy services to assist in the making of the complaint. And as we know, I mean, just in this, it was this month or April last year, HIQA released the Fundamentals of Advocacy in Health and Social Care guidance. So, you know, that is certainly something that we need to be considerate of and ensure that we have a robust, comprehensive advocacy service in place to be able to support this type of activity. Staffing certainly came under a level of interrogation. In this case, inspectors were not assured that there were sufficient numbers of staff available to meet the needs of residents, and that staff were being designated to cover staff absences in other departments. Now, staffing ratios and levels is always something that comes under a certain amount of interrogation and question. But certainly, and I suppose it is so dependent on the level of the number of residents, the level of their dependency, etc. But just if we look at this as an example, there were 6 care staff assigned to provide care and support for 46 residents on the day of inspection. And of these residents, 12 were maximum dependency, 9 were high dependency, and 15 were medium dependency. And certainly in this case, HIQA deemed that was insufficient. Care staff were busy with care tasks and therefore had little time for meaningful social interaction with the residents, which is central to the process. And nursing staff were observed answering phone calls and the door to visitors in the absence of reception staff. So you know, individuals being spread very thinly across the ground, and the impact being on the quality of care being provided to residents. Further actions were required by the registered provider to come in line with the whole time equivalence as set out in the statement of purpose. Their statement of purpose stated that there should be 52 healthcare assistants and 20 staff nurses employed to provide safe care. On the days of the inspection, they had 41.5 healthcare assistant posts and 16.5 nursing posts. So that was not in line with their statement of purpose. When again they looked at the rosters, it was identified that staff nurses were working 96 hours over a 2-week period, with one nurse working 102 hours, and that was deemed as not being sustainable. So they are the types of non-conformances that are coming up under that Regulation 15 and staffing. Other types of examples under that was that, again, not sufficient staff on duty, residents having breakfast at 10:30, residents still waiting to get up at 11, nursing staff not having the medication round completed by 10:30, and only one member of staff on duty to clean the whole designated centre and do laundry for 31 residents. Linking to that, I suppose, is our Regulation 16, training and staff development. We see this again repeated time and time, and staff not having their mandatory safeguarding training or mandatory medication management training updates. Supervision certainly came under a little bit of consideration here, and staff not having appropriate supervision or appropriately trained to deliver the care to residents. There was inadequate supervision of staff on night duty, resulting in a culture that was task orientated and not resident centred. So again, looking at that human rights approach in that regard. A review of sample staff files found that where a staff member had breached a policy, a performance improvement plan was not implemented, and staff continued to work without any special oversight or supervision arrangements. So there's certainly that expectation that where an issue does arise, there are additional controls and supports put in place to address that going forward. Just briefly in relation to the contract for the provision of services, it was something slightly different that came up while contracts were in place. It was noted that contracts did not have the name of the registered provider as part of the contract, but a third party. And then older and newer contracts varied in relation to this mention of a third person. So it's important that the register provider being named in that regard. Although a contract had additional charges, the terms relating to bedrooms and the number of other occupants was not recorded in the contracts of care, which obviously is a requirement. Just briefly in relation to Regulation 31 and notification of incidents, although quarterly notifications were being submitted, a number of requirements in relation to restraint, or not all of the restraints that were being implemented were identified, and that included sensor mats, locked doors to exits, cigarettes and lighters being held by nursing staff. So none of these were being reported as restraints in that regard. Now, if we move under the second dimension, quality and safety, as I said, fire precautions was under all of the 36 reports that were reviewed, it was the only one that carried a non-compliant red risk. So again, that consistency coming through from previous years. So some of the findings in relation to that, and as I said, these are red across the board. There were inconsistencies and a lack of clarity in relation to the fire evacuation strategies. Differences were being identified between local policy, evacuation plans displayed on walls, staff training and knowledge, and complete evacuation drills. And I suppose this can occur where there are piecemeal efforts to try and achieve the requirements and make a little change here, and then it's not reflected in something else. And the model itself becomes very out of sync, that there is no holistic approach to the fire precaution requirements, which is central to ensure its effectiveness and comprehensiveness within the service. Inspectors found that staff responses in what action they should take in the event of a fire alarm sounding were very poor and inconsistent. Signage on ground floor directed staff to fire panel at reception. However, some staff felt that they should attend the fire panel on the first floor, and other staff just weren't clear on what fire panel that they would go to. So again, it's not just about having the documentation in place, it's about having a real understanding with the staff and those providing frontline care, that they have a real understanding of what to do should an emergency situation arise. The courtyard area, which was a designated means of escape, had a padlock on the gate, and this was a direct contradiction with the fire safety certificate, which detailed it must be unobstructed and free from fastenings. In other cases, excessive amounts of CO2 cylinders and flow gas cylinders were found in external storage area, while 2 oxygen concentrators in a main storage area, which was filled with supplies, and there was another 2 also found in a linen cupboard, and no hazard signs were detailed in these rooms. In another case, residents' documentation, their PEEPs weren't being kept up to date, so the information on those residents' doors wasn't correct. Some residents didn't have any PEEPs available to guide on evacuation methods for these residents. And in another case, PEEPs reviewed on the day hadn't been reviewed in over 15 months and did not reflect on the change in condition and the needs of these residents. The fire safety policy itself was poor and not being implemented. There was no consideration for the policy for the vertical evacuation of residents on the first floor. Those fire drill records lacked the detail required to provide adequate assurance of resident safety, and records showed that 1 fire drill had been completed in 2023. However, their own local policy stated that monthly fire drills would be completed. And that's important to note, that if you're setting the bar yourself in relation to your policies and procedures, and you don't achieve that, then it is identified as a non-conformance. Safe and appropriate containment was not in place as a result of poor maintenance of fire doors. Fire doors, again, consistently coming up month on month. Compartment doors to corridors weren't closing effectively, doors held open by wedges, and a communal room had a dustbin holding the door open. Linked to that, I suppose, in relation to Regulation 17 on premises, again, a heavy hitter in 2022. In this case, we had no arrangements been made to relocate a resident from the first floor to an alternative bedroom on the ground floor as a result of those changing dependency levels. So that constant requirement for review and update depending on the residents' needs. Visitors' rooms were not available as they were now in use for storage. Layouts of twin bedrooms did not facilitate the placement of required furniture for a resident. There was insufficient storage for assistive equipment, and grab rails were not fitted on some of the ensuite and communal toilets that were in place. Wardrobes required review, drawers and doors not closing correctly. A bedroom had no call bell, and another room, the call bell wasn't working. Ventilation in some of the bathrooms not being appropriate, furniture in communal rooms not being in good condition, damage on walls and doors, and a section of guttering was leaking. So pretty broad spectrum, and again, something we see these coming up again and again throughout the services. Residents' rights, as I said, more and more focus, I think, will come through under this regulation as we move forward, particularly, as I said, in relation to that judgment support framework changes. Some of the ones identified under our review, residents had restricted access to dining room, oratory, and 2 visitor rooms. And on the day of that inspection, they were observed to be locked at various times of the day. Some residents that were living with cognitive impairment who required assistance with their meals were not facilitated to have their meals in the dining room. There was no documented evidence that activities took place in 3 days of the week, and the activities planner that was reviewed had a heavy reliance on television, movies, and radio. In another facility, higher dependency residents spent most of the days in the room, and they had very little engagement with staff. And again, that's going to link with our resources that are available and our staffing under that requirement. Residents' choice of when they went to bed was not supported, and residents in multi-occupancy rooms did not have effective privacy screens. The residents' survey results highlighted a dissatisfaction among residents in relation to the overall care provided. However, the register provider had failed to respond to resident feedback survey results. So again, linking it to that governance model and ensuring that the voices of the residents and their families are being heard and acted upon. Infection control, access to clean rooms wasn't readily available on the day of the inspection. Oversight of these areas was not completed by the register provider. So again, they're pushing for that responsibility, which is detailed within SI, our oversight regulation, it does lie with the register provider. So it's important that we consider that. Staff had access to 2 clinical hand hygiene sinks, but neither of these met the required specifications. The sinks were located in the sluice room and laundry, and both of these doors were locked and not easily accessible. Staff were observed walking on corridors with gloves on and carrying used linen. Household staff used disinfectant spray and wipes to clean residents' rooms and bathrooms, and they felt this was not in line with the guidance provided with staff, which advised cleaning with detergent for the majority of items. Regulation 5, individual assessment and care planning, I thought was important to note. In some cases, residents' care plans were not being reviewed, completed within that 4-month timeframe. So that is still very much a focus of the under Regulation 5. Care plans reviewed were incomplete and did not contain up-to-date information. A resident was reviewed by a dietitian, but those recommendations were not recorded in the resident's care plan. Residents' pre-admission assessments were not fully completed, leaving gaps in information which did not provide assurance that that resident's needs could be met by the service. Where residents had responsive behaviours, care plans did not clearly describe what may lead to anxiety and a physical response, or how staff were to manage that situation to support the residents to return to feeling calm. So looking for a much more detailed care plan, incorporating those triggers and required responses should an incident arise. Staff were found to be overly reliant on information obtained from previous admissions, and as a result, the standard of assessments and care planning did not assure residents safe and appropriate care. So, particularly for respite care, where a resident may be coming in and out, that there was over reliance on that information that was previously held, rather than updating that information, completing new assessments, and ensuring that the current needs of that resident was being addressed. One resident's assessment on admission had not identified a number of known oral health care needs, even stating in one record that no care plan was required, although that resident did have significant needs in that regard. Wound assessments and care plans for a number of residents had not been updated to ensure that the staff had correct information they needed to provide safe and appropriate care. Briefly looking in relation to Regulation 8, protection, records of accidents and incidents reviewed identified potential safeguarding risk. However, that was not identified or investigated or managed in line with its own safeguarding policy. So, looking at incidents as they arise and ensuring that should there be any underlying safeguarding risks, that they're appropriately addressed in relation to the internal policies that are there. Action was required to ensure that all staff were familiar with what constitutes abuse and the actions to be taken to detect, prevent, and respond to abuse. And staff that were spoken to did not identify the presence of unexplained bruising as a potential safeguarding concern. So really a lot of interaction with the staff and ensuring that they have the competencies and skills and knowledge to be able to assure safe care for the residents. Healthcare then under Regulation 6, one resident who was admitted to the designated centre 2 months prior to the inspection had not been seen by their nominated GP by that time. Another resident who had been residing in the centre for many years had not been seen by their nominated GP in 17 months. And 1 out of 4 GPs attending in another centre did not have oversight or take responsibility for the residents' end of life care needs. So some significant concerns in that regard. So that brings us to the end of our whistle-stop tour in relation to some of the key findings and areas of concern for HIQA as they have arisen from the review of our reports. And hopefully you can take some of that learning and bring it back into your own service and ensure that the required controls are in place and so that you could continue working towards compliance and safe quality of care. I'd just like to say HCI Care Tools is available to you. It's an online store where you can purchase your evidence-based documentation as you need, policies, procedures, forms and templates, something for everybody in relation to it. And I know that kindly Rosemary has given an excellent discount rating for the month of May, and she's happy to discuss any of those things with you at any stage should you have interest in some of our services that we provide to the residential care service for older people. With that, I think that's everything, and I hope it was of value to you today. Rosemary will circulate a copy of the slides to all our attendees this morning, and if you have other members or other colleagues that you think might be interested in some of the content today, I know that Rosemary will be circulating the link of this webinar. But thank you very much for everybody who attended, and we will look forward to catching up with you again very soon. And we will have more information, we hope, to support you on your ongoing service provision. So thank you very much.